Hi, in this recording, we are going to continue talking about pharmacology of the neurologic and musculoskeletal systems. In this one, focusing on stimulants. So, here we're really focusing just on neuro and not so much things that affect movement, but we're really affecting the cognitive things in the brain. So, the first disease process that we use stimulants for is ADD, ADHD. This is the most common psychiatric disorder in children, much more commonly seen in boys than in girls. But the symptoms here are an inappropriate ability to maintain an attention span. Now, this is not just at school, but also things like watching TV, playing games. They'll manifest this in all areas in order to have a true diagnosis. Children who just have trouble concentrating at school while they may be on medications, a lot of times that is not a true ADD diagnosis. So we use medication. We use stimulant medication for this, and we use it in the same medication for kids and for adults. So some people grow out of it as teenagers. Other people have to continue taking it even into adulthood. Narcolepsy is another disorder that we use stimulants for. So these cause sleep attacks, and that can cause car accidents. And about 70% of people who have narcolepsy have fallen asleep while driving. It's suddenly. This isn't like you're getting sleepy. Okay. Cataplexy is also seen in a lot of people with narcolepsy, where they have acute weakness and they will often fall. We also use them in certain respiratory depression. Specifically, we'll use it in a lot of neonatal apnea. We use stimulants. So neonatal apnea is common in about 25% of our premature births. Those babies will often need a CPAP or a BiPAP, and so that's actually what's shown in this picture here. We don't use them very often for this, but we will use stimulant medications for that to keep them breathing. Also in respiratory depression, that is seen post-op with anesthesia, with narcotics and things. And so we use things like caffeine. We use theophylline. Theophylline is very commonly used as a stimulant medication. It's also used to improve breathing. So all of those are stimulant medications that we will use. And we've even talked about theophylline and aminophylline before when we talked about the respiratory system. Obesity, 30% of Americans qualify as obese. 2/3 are overweight. And so that's a lot of people. And there's a lot of health risks that are associated with obesity, including things like hypertension, high cholesterol, which leads to coronary artery disease. Diabetes is linked to obesity. Type 2 diabetes is linked to that. And stimulants can be used for that as well. And then finally, migraines. So migraine headaches are another type of thing that we will use a stimulant for, a stimulant medication to treat. And even something as simple as Excedrin has caffeine in it because of and that caffeine is a stimulant, and that will help relieve the symptoms of migraines. So when we're talking about stimulants, they stimulate a specific area. They may stimulate dopamine receptors, adrenergic receptors, serotonin receptors, but stimulants in general are used to treat multiple things, like we just talked about. They are first line treatment for ADD and narcolepsy. They may not be first line treatment for the other things that we talked about. Amphetamines are the primary one that we use to treat ADD and narcolepsy. So I've got some listed amphetamines here. It's dextroamphetamine, that's Dexedrine. Amphetamine aspartate, that's Adderall. Strattera is not actually a stimulant. It is an SNRI, or a norepinephrine reuptake inhibitor. Strattera actually has a black box warning that it does increase the risk of suicide in adolescents. So you do have to be careful with medications that affect serotonin and norepinephrine levels, because it can they almost all have a have a warning about suicide associated with them. So when we talk about our amphetamines, they stimulate a lot of things, okay? So obviously mental alertness, that's why we take them. That's the goal of them. They also cause euphoria, which leads to a very high potential for abuse, okay? We want them to increase mental alertness. We want them to decrease drowsiness and fatigue. Prolonged wakefulness is, obviously the intent, and that then when we tell people about how to take them, we say take them in the morning. If you take it twice a day, they take them at morning and at noon, which makes sense, right? It keeps them awake. So we don't want them taking it at bedtime. They do have respiratory effects. So they do relax our bronchial smooth muscles, which makes it easier to breathe. So that's why we use them for a lot of our respiratory disorders they're not necessarily linked to respiratory depression, but rather are, severe asthma. So they do help with those as well. Now, adverse effects, we do want everything, we want some things to be sped up, but we don't want everything sped up. Unfortunately, amphetamines speed everything up. And so, some of our adverse effects, all of our adverse effects are related to the sympathetic nervous system. So if you think about that, your heart rate's up, your blood pressure goes up, you might have palpitations, you might have dysrhythmias, you might get anxious, nervous, we'll have nausea and vomiting as we pull blood flow away from the GI tract, so it inhibits peristalsis, and so food is not going to be digested as well. It increases urinary frequency, both because it actually inhibits bladder contraction, but also because a lot of them have diuretic effects. So we did talk about MAOIs when we talked about depressants, and we need to make sure that they're not taking an MAOI at the same time as this, and we do in fact need a kind of a washout period when we have somebody on an MAOI. Luckily, those are not common anymore at all. Other drugs that we use for ADD and narcolepsy are, first methylphenidate Ritalin. This was kind of this is a stimulant drug. They're both stimulant drugs. This is a Schedule II drug. It was the very first drug that we had for ADD. We also used it for narcolepsy. It comes out, right now it's Concerta. That is an extended release form. It is available in generic now, but this was given, we had this on the market 25, 30 years ago, if not longer. Provigil or modafinil, this is specifically for narcolepsy. This is not used for ADD. The other thing that we'll give it for, other than narcolepsy, is shift work sleep disorder. And I have that in italics because this can happen to nurses. So people who work a variety of shifts, Provigil will help you stay awake when you're supposed to be awake during a work shift, for example. Nuvigil is similar, same ending there, dafinil. These are only Schedule 4s, meaning that they don't really have the potential for abuse because they don't really cause that euphoria. So that's why. So nursing implications, I said take it, we take it at breakfast and lunch. We definitely want to make sure that we don't take anything after about 5 o'clock in the afternoon. So 4 to 6 hours before bedtime. That way they can still sleep. Taken on an empty stomach. So when I said breakfast and lunch, I didn't mean like after they eat. I mean like that time of day. I just realized that sounded like I was contraindicating myself. Drug holidays may be ordered. And that is something like, so sometimes we will order a holiday where the kids only take the meds Monday through Friday. Sometimes they'll take them 7 days a week, but have 1 week off a month. Often kids don't take these during the summer. So there's a lot of different ways to do a drug holiday when they're not actually taking any of the medications. The parents have to keep a journal of symptoms. So exactly how they're responding to therapy. The other thing they have to keep in a journal is monitoring their height and weight, because these stimulant medications actually suppress growth. And so they will have they'll be tinier for their age, basically. They won't follow the growth curve. All right, another type that we're going to talk about are the anorexiants, and these are used to treat obesity. They actually suppress the appetite control centers in the brain, and then they increase your basal metabolic rate, so you're burning more calories when you're still at rest. It mobilizes your fatty tissue, so that you can get rid of it. It enhances cellular glucose uptake. And it helps you to not absorb as much dietary fat. That's one particular one, and we'll talk about that. So phentermine was like the initial one that we used. Benzamphetamine, methamphetamine. So they'll use the same ADD drugs for. They'll use the same ADD amphetamines that we use in order to lose weight as well. Diethylpropion, not very commonly prescribed. The newest medication out there is actually Qsymia, which is a combination of phentermine and topiramate. So you'll remember we talked about topiramate or Topamax when we talked about seizures. So, but the combination of those two medications are it's a combination drug called Qsymia that is very successful as well. Other drugs to treat obesity, we have, I put Qsymia again on here, because it's not one of the standard drugs. Like we basically just took our drugs that we use to treat ADD and did it. Orlistat. So Orlistat is a generic name, and it is marketed as Xenical and Ally. So this is a non-stimulant drug. And the mechanism of action on this, can you close the door, please? Quickly. So the way Ally and Xenical work is that they inhibit the absorption of fatty foods, and it's because they inhibit lipase, so you can't break it down. So it binds so those two drugs bind to lipase, meaning that you can't break down and absorb fat. Restricting dietary intake of fat to less than 30% will also be recommended in this, because one of the side effects of Ally and Xenical is oily flatulence, oily spotting, some incontinence of oily feces. So, basically these, you have so much fat in your stool that's undigested that they can't control it. So, you have to not eat as much fat as well. Saxenda is actually liraglutide, which that's when given for diabetes, it's a GLP-1 med, the kind that made you feel full longer, one of those incretin mimetics. And what they figured out was that Victoza and those other incretin mimetics, they made you lose weight, right? So they said, well, let's just market this for weight loss. And so Saxenda it's a larger dose of Victoza. It's a daily injection. I think it's daily, but you get full faster and you stay full longer. And so this is also very popular right now, but it is Victoza, just marketed under a different name. Side effects from all of these include sympathetic nervous system effects, okay? So elevated heart rate, palpitations, high blood pressure, anxiety, agitation, all of those things are going to be side effects there. So what does it mean for us when we're teaching our patients? Obviously, if they're taking it to lose weight, it's part of a weight loss regimen. So they need to follow the instructions for diet and exercise. They are stimulants, so we take them in the morning. Caffeine is also a stimulant, so they shouldn't take it with a cup of coffee. And with Orlistat and Ally, they may need to take supplements of the fat-soluble vitamins, because they won't be able to absorb them and hold on to them as well. So vitamins A, D, E, and K will often need replaced there, especially especially vitamins A, D, and E. Those are going to be the big ones there. Contraindications for these are going to be people who already have heart disease, in that maybe they've got heart dysrhythmias, maybe they've got hypertension, maybe they've got coronary artery disease. We don't want to put the stress on their heart. Hyperthyroidism, you already have excess sympathetic activity, so we don't want to do that. We also will not give these to somebody with an eating disorder. That is a completely new ballgame. So we are not going to give somebody an anorexiant drug to help them lose weight if they have an eating disorder. And again, here's those MAOIs, okay? Like I said, MAOIs are not very common anymore, but they interact with almost everything. Now let's talk about migraines. So migraine treatment for the longest time was only with what we called our ergot alkaloids. And basically what those did was that they constricted the blood vessels in the brain. And so if you constricted the blood vessels in the brain, you had less pressure and therefore less pain. And those were, that was just all we had for the longest time. And then Imitrex was invented. Imitrex is an SSRA, selective serotonin receptor agonist, okay? So our antidepressants are SSRIs, which are selective serotonin reuptake inhibitors. These are different, okay? So these are the drugs known as the triptans. And what they do is they also cause vasoconstriction, but it's different receptors that they stimulate. They also reduce the production of neuropeptides, which are inflammatory and cause more of the pain. And so these were a game changer for migraines. So Imitrex was the first one, sumatriptan, and there's a ton of them now. So Imitrex was originally an injection. It was a self-injector thing that people just pushed a button and it injected. And now it comes in tablets as well. And there are tablets, there are injections, and there are nasal sprays in here. So lots of different methods of taking it. The injection is still the best way, and that's because a lot of people get nauseous with migraines, and so they can't take a pill like that. Adverse effects of triptans, not a lot. So the vasoconstriction, it's supposed to do that. Okay. Sometimes irritation at the injection site, and maybe some tingling or some flushing, but really they are really, really well-tolerated medications. Ergot alkaloids, not so much, okay? They cause nausea, vomiting. They caused muscle pain, dizziness. They caused rebound headaches. And so your patients would take them continuously. And so that's one of the biggest issues with the ergot alkaloids. And so luckily those have been pretty much replaced in everybody. All right, so some nursing implications. The SSRAs, remember these are our triptans, make sure they know how to administer it. If you are in an office where you're teaching somebody how to use the injection, you'll always have a sample one that they can practice with. And so they need to practice giving the injection to themselves. Sometimes family members will practice as well. It does come in a nasal spray also. Some of them come in nasal sprays. Like I said, some of them come in tablets. Dissolvable wafers, that just means that they stick it in their mouth. It's a buccal lozenge, okay? Always remind them to keep a response keep a journal, not only about whether or not the med works, but what triggered the migraines. Because one of the big things with migraines is identifying what triggers them so that you can avoid the triggers as well. For ergot alkaloids, remember, lots of side effects, okay? And so we have to make sure that they know when to call the doctor. And that includes if they have chest pain, if they are having stroke symptoms like confusion, slurred speech, vision changes. All of those can happen because of the vasoconstriction in the brain with ergot alkaloids. So lots and lots of side effects with those. And those, they need to seek medical attention. Our SSRAs, that's just not, those just aren't, they just don't happen with those. So before you give a stimulant of any kind, always look for abnormal heart rhythms, seizures, palpitations, liver problems that could indicate that maybe they're not going to metabolize them very fast. And if they don't metabolize the drug fast, then you know you're going to have the effects for a lot longer. And then look for whether or not it's working. So, is your patient with ADD able to concentrate? Is your patient with obesity losing weight? Is your patient with narcolepsy staying awake? And then, is your patient with migraines still having them? Even if they are still having them, are they reduced? So it, that's one of the big things that that will determine which medication we use as well. So with our triptans, sometimes we will go, if one medication doesn't work, sometimes we'll try something different. All right, review question. A patient is prescribed an anorexiant. Which statement will the nurse include in patient teaching? Pause and answer this to yourself. That is D, avoiding intake of caffeine. So caffeine in any form is, remember that that's a stimulant. And so we don't want to combine them with other ones because then we're just asking for things like heart palpitations and stuff like that. They take it in the morning to prevent interference with sleep. These are taken on a short-term basis. We don't give them for this long. Usually it's just a few months. A dry mouth is going to be a common side effect of these medications. And so we just tell them take sips of water and or sucking on ice chips, sometimes sucking on hard candy, things like that. All right, before administering a serotonin agonist, it is most important for the nurse to assess the patient for a history of what? And this is A. You need to complete a thorough cardiac history as well as measurement of blood pressure and pulse rate and rhythm. So if your patient has a history of hypertension, remember that it does cause vasoconstriction. And so if they have really bad high blood pressure, now a history of hypertension that is well controlled is not going to be a big deal. But if you take their blood pressure and it's like 200 over 120 and you give that patient an SSRA, you could potentially cause a stroke. Okay. And you don't want to have something like that, obviously. So we will typically not even prescribe triptans for people with really severe cardiac history. All right, a teenage boy will be receiving atomoxetine as part of treatment for ADD. Which statement about this drug therapy is accurate? Pause and answer it to yourself. And that is C. We monitor the patients for possible suicidal thoughts and behavior. So we monitor them closely. We also look for any kind of history of that before it's prescribed. Remember, that's Strattera. Okay, and it is not highly addictive. Remember, this is the one that's not an amphetamine. All right, a patient wants to take orlistat or Xenical to assist in her weight loss, but she's wary of its unpleasant adverse effects. I'm pretty sure that Ally on the box, I think I saw a picture of this once. It says on the box can cause anal leakage. What measure can be suggested to reduce these effects? And that would be A, restricting dietary intake of fat to less than 30% of your total calories. That'll help reduce it because then there's just not as much fat in the intestines to begin with. And by the way, if you reduce your fat intake, you also lose weight so that it helps there too. All right, let's teach your patient. Oh, these are, yes, okay. So Mr. Hendricks, Jimmy, he's transferred to your unit where he's being treated for respiratory depression after surgery. Discuss nursing management for a patient who is taking doxapram. So pause, look that one back up, answer that to yourself. All right, so we use that in ICUs to stimulate respiratory rate in patients with respiratory failure. So it may be useful for treating respiratory depression in patients who've taken excessive doses of things like fentanyl, which won't respond as much if the Narcan's not working. Okay. Number 2, Mr. Osborne or Ozzy is an older man with narcolepsy. He's taking modafinil as part of his treatment. What teaching is needed regarding adverse effects and safety in the home? So this one, we want to make sure that he takes it in the morning, or if he's taking it for shift work, then they take it about an hour before they start working, so that they stay awake. Okay. And so people who take this for shift work disorder will often take it at night so that they can stay up all night. All right. Ms. Joplin or Janice is taking Orlistat as part of a treatment plan for obesity. However, after 1 week, she tells you that she hates the adverse effects. How can these be managed? All right, this is the drug Ally. Common side effects of this include oily spotting on underwear, flatulence, urgent bowel movements, fatty stools, diarrhea, inability to control diarrhea, lots of nasty ones. Side effects do usually decrease with time, and if she would decrease the amount of fat intake in her diet, it will also help. All right, Nancy has been unsuccessful in preventing migraines and has been prescribed sorry about the typo there, selective serotonin receptor agonist, or SSRA, sumatriptan. So that's Imitrex. Number 1, what patient teaching would be included for Nancy regarding the action and route of administration? Pause. Answer that to yourself. All right, so this is specifically for migraines. Remember that these are the meds that replaced our ergot alkaloids, and this will work even for severe migraines, usually within a couple of hours. Our fastest onset forms are going to be not going to be oral. They're going to be either nasal spray or even better, injection. So you have to make sure that that we don't do or that she doesn't take an oral form if it's a really severe migraine, because then it would cause, then you've got that nausea and vomiting. What patient teaching should be included for Nancy regarding adverse effects or contraindications? So we are going to ask about history of severe cardiovascular disease, because remember, they do vasoconstrict, and they could cause angina. It's not very common, but they could cause it. Injectable dosage forms, though, as long as your patient doesn't have a history of cardiac events, honestly, the only thing is going to be a little bit of an irritation at the site of injection. All right, number 3, what medications would Nancy have been prescribed for first and second line preventive therapy? So what do we prescribe to prevent migraines that we have talked about already? Think about that. So our first line drugs for preventive therapy are often beta blockers like propranolol, or brand name Inderal. We also have learned about medications that are prophylactic, that are anti-seizure meds. So Topamax or topiramate, the valproic acid medications can be prescribed. Amitriptyline or Elavil, that can be prescribed. Second line therapy are things like, sometimes we'll even prescribe like calcium channel blockers. So those are preventive therapy before, because ideally anybody who gets migraines on a routine basis should be on a preventive therapy as well as having something for an actual migraine that occurs. All right, number 4, she asked about the effects of caffeine. What do you say? So caffeine is a stimulant. Caffeine reduces cerebral blood flow. That is why it helps with headaches. It also potentiates the effects of other pain meds. So that's like Excedrin. That's why Excedrin works. So and then it is also a diuretic. That's just as a, which can reduce intravascular blood volume, which can also help with headaches. All right, Nancy also asked the nurse if there are effective non-pharmacologic treatments for migraines. What evidence-based answer can the nurse provide? So this is interesting if you happen to look this up. They have TENS units now for migraines, which are the transcutaneous electrical stimulation, where it sends a little bit of an electric current through the skin, and it stimulates your trigeminal nerve that is often associated with migraine. So those are kind of an interesting thing. The other non-pharmacologic treatments are things like a cool environment, a dim environment, quiet, cold compresses. All of those are non-pharmacologic treatment. All right, Stacy weighs 300 pounds. She's been trying to lose weight for the past 5 years. She's attempted numerous short-lived diets as well as vigorous exercise. Over these years, she's been able to lose between 50 and 125 pounds and has, within the next 6 months, gained the weight back. She comes to the weight loss clinic today to attempt weight loss again. In addition to a diet of 1,200 calories per day, she will begin to take the drug phentermine. She has many questions. Number 1, she asked the nurse, how effective will this medication be in helping me lose weight? How do you respond? All right, so anorexians like phentermine are, they do a good job, but really you have to adhere to the diet. So you can't take the medication and continue to eat the same amount as you always have. But what this does is it makes you not as hungry so that you don't want to eat the same amount as you always have. So it's not the only thing. You also have to eat well. All right. Stacy's worried about side effects. So what are the side effects of these medications? So of phentermine, we're not talking about the anal leakage here. All right. So phentermine can raise blood pressure and it can cause palpitations. She might get headaches or dizziness. And so those are the things that we're going to tell her about. And those are the things that she needs to report as well. And then finally, she says, does it interact with any drugs? Answer to that is always going to be MAOIs, but then also anything else that's a stimulant, okay? So if we combine it with another CNS stimulant, then the side effects are going to be much greater. So we're going to see insomnia, potentially seizures and cardiac dysrhythmias. So we don't want to do that. And that concludes this video.